everyone, and thank you for taking the time to join us for today's webinar hosted by the American College of Lifestyle Medicine titled Lifestyle Medicine, Foundation of Whole Health Revolution. My name is Caitlin Pauly. I serve as the Deputy Director of Practice Advancement and Administration at the American College of Lifestyle Medicine, and I have the pleasure of offering some opening announcements and introducing today's speakers. I want to begin by sharing the definition of lifestyle medicine. Lifestyle medicine is a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions, including but not limited to cardiovascular diseases, type 2 diabetes, and obesity. Lifestyle medicine certified clinicians are trained to apply evidence-based whole person prescriptive lifestyle change to treat and when used intensively, often reverse such conditions. Applying the 6 pillars of lifestyle medicine, a whole food, plant-predominant eating pattern, physical activity, restorative sleep, stress management, avoidance of risky substances, and positive social connections also provides effective prevention for these conditions. ACLM is the professional medical association for those dedicated to the advancement and clinical practice of lifestyle medicine. ACLM provides training, continued education, certification, and a variety of resources for physicians and health professionals. We are united by the desire to achieve our vision, a world wherein lifestyle medicine is the foundation of all health and healthcare. For all of those in our audience who are interested in learning more about lifestyle medicine and food as medicine, ACLM is offering complimentary registration to a 5.5-hour CME CE course until September of 2025. We encourage you to register for the course using the QR code on the screen and/or share it within your networks. The learning objectives for today's webinar are: 1, define value-based care and its importance in healthcare transformation. 2, examine how integration of lifestyle medicine practices can influence key measures, quality metrics, cost containment, and patient outcomes. 3, explain how lifestyle medicine fulfills foundational elements of whole person care. And 4, summarize how lifestyle medicine offers a framework to deliver whole person care in fee-for-service and value-based care models. I'm honored to welcome and introduce our speakers for today's webinar. The first speaker, Dr. Karen Johnson, serves as the Vice President of Practice Advancement for the American Academy of Family Physicians. Her 30-plus years of diverse experience includes working with employers, payers, physicians, and health systems as a translator, bridge builder, and change agent. She possesses a broad understanding of complex healthcare ecosystem with specific expertise in value-based strategies, advanced provider payment models, primary care transformation, health data exchange or interoperability, healthcare systems, and health policy. I think everyone on this call can align with her long-standing personal mission to make healthcare work better for more people at a cost they can afford. Our second speaker, who many of you may know well already, is the President-elect of ACLM, Dr. Padmaja Patel. Dr. Patel is a lifestyle medicine expert, a board-certified internist. She serves in a variety of leadership roles, including at the National Quality Forum, the World Lifestyle Medicine Organization, and a clinically integrated physician network in Midland, Texas. Within ACLM, she leads the Clinical Practice and Quality Committee. Dr. Patel strongly advocates for the sustainable integration of lifestyle medicine across the clinical care continuum, within workplaces, and within population health strategies. Thank you, Drs. Patel and Johnson, for being with us today to discuss this very timely and important topic. I'll hand it over to you, Karen, to get us started.
All right. Well, thank you, Caitlin, for that great overview and for the warm introduction. I'm just delighted to be here. Dr. Patel and I have been on a journey together, really understanding each other's worlds from the perspective of the family physician doing, full scope primary care, and then what she brings from the lifestyle medicine perspective has been so valuable. So I get to kick us off today, and for today's discussion, I really want to point out that all of this is really grounded in a foundational belief that high quality primary care is synonymous with value-based care, which is synonymous with whole health care. And while all of these terms sometimes have or are interpreted as having distinctly different meanings They actually have a lot in common. And that I think for the purpose of today's conversation, regardless of the term you use, applying the principles and perspectives of lifestyle medicine within the context of high quality primary care has the potential to really improve outcomes for patients and produce benefits for physicians and other members of the care team. And so today, the learning objectives that I get to cover with you are to really define VBC and its importance in healthcare transformation, and to take a close look at how lifestyle medicine can influence key measures, such as quality metrics, cost containment, and patient outcomes in a value-based care context. My portion of the talk is going to be anchored in these three key points. First, that primary care is the foundation of a high-performing healthcare system that provides equitable access to high-quality care. Second, that the U.S. approach to healthcare payment, we affectionately refer to as fee-for-service for the most part, is incompatible with the delivery of high-quality primary care. And finally, that we come from different perspectives and use different words, whole health, lifestyle medicine, team-based care, value-based care, to describe what is essentially high-quality primary care. And so the National Academies of Science, Engineering, and Medicine helped really underscore point one, that primary care is the foundation of a high-performing healthcare system that provides equitable access to high-quality care. You see depicted here, implementing high-quality primary care, rebuilding the foundation of healthcare, represents a 2021 consensus report, really already being described as seminal or landmark in terms of describing really the importance of primary care. And really, I think, centers on that point that it is the foundation to high quality care and for everyone. And that it really, from that point of view, really becomes a public and common good, something we all should be invested in and working to strengthen across the US healthcare system. So I hate to talk about the things that aren't working, but let's just start with the problem and why we need this focus and even this conversation today. So this is a graph that comes from a study of international comparative work that is done by the Commonwealth Foundation. It's been done for years. They titled this study "Mirror, Mirror, How Are We Doing?" And it's really insightful. What you see depicted here is a graph that shows on the x-axis at the bottom, healthcare spending as a percentage of GDP, with higher health spending over to the right. And then through a series of really in-depth data analyses, the Commonwealth Fund study takes a look at overall health system performance, considering access, cost, quality, experience of clinicians, experience of patients. They look at it about from every system you can, and they come up with a composite measure of performance. And you can see that the US sits over here on the right, sort of all by ourselves with the highest spending and the lowest overall performance, whereas most of our peer nations are centered somewhere with much higher performance and more moderate spending. So what's happening there is the other really great thing that comes out of this study, which is, what do high-performing systems do? They provide free universal coverage, and they remove cost barriers for patients. They reduce the administrative burdens on patients and clinicians. They invest in social services and worker benefits. And as you can see bolded there at the bottom, and importantly for the conversation we're having today and for the work that we do at the AFP every day, they invest in primary care systems to ensure value and equitable access. So that level of investment that is just right, I think we're still working to figure out in the US. We look at what other nations are spending on primary care, and the estimates range from 12 to 17% of total spending. Of course, their denominator, the total spending, is lower, so it's going to obviously look higher, but we know that the way primary care systems are structured in other nations and the way they are resourced is quite different than the US. Our best estimates in the US are that we're actually spending only about 6% on primary care. You can look at it from a lot of different perspectives, and the population you're looking at matters. For example, the overall spending on primary care and Medicare actually looks quite lower because the overall spending on other services is higher in a more complex patient population, but the overall estimates range anywhere from about 4 to 7%. For those states, and the states I would just mention are really leading the charge on increasing investment in primary care, those estimates can get as high as 8 or 10%. So let's just talk about what low primary care spending has led us to today. We know that primary care practices are under-resourced. I think the pandemic showed this in a really, really significant way. We know that the workforce is burning out and they are leaving clinical practice settings. What this does is, of course, compromise and limit patient access. And those limitations are not sort of evenly or equitably distributed. And what we have is a lack of equitable access to quality care. And so you may say, I don't care about primary care. I just really care about being able to get care when I want and need it. Well, guess what? We can't really fix those problems unless we really address the root cause. And so we spend a lot of our time working on how we can invest in primary care practices in ways that really improve and address worker well-being, that really support a sustainable primary care workforce, a really happy and satisfied sustainable primary care workforce, which helps us to expand capacity and create the equitable access and quality of care that we are all seeking as individuals and for our loved ones. And so I think that, for the purpose of our conversation today, I think the really interesting part of the conversation is how do we broaden the lens in thinking about delivering primary care in ways that actually benefit from things like lifestyle medicine or I shouldn't say things, perspectives and experiences that I think Dr. Patel and her talk will really bring to life for us today. So point number 2, the U.S. approach to healthcare payment, which we affectionately refer to as fee-for-service, as I mentioned, is incompatible with the delivery of high-quality primary care. So the success formula under fee-for-service is pretty straightforward, and we know that that on its own is not serving primary care well. So to be successful under primary care, which has come under criticism, not just in the primary care sector, but more broadly, because in order to earn more revenue, I have to do more services or higher cost services. And that's kind of at the core of the problem, as mentioned by Dr. Rosenthal in the quote you see here on the slide. Some of the specific critiques of fee-for-service is that those incentives are misaligned with health or health improvement, that they are really focused on delivering services mostly associated with sick care. That the payment for under this sort of mechanism doesn't really consider outcomes. It doesn't matter whether the patient gets better or doesn't. The payments are made, and they are really made regardless of the appropriateness. While we have these things we talk about around medical necessity, there's a range of services, and there's been a lot of work in this realm around what is really a high value service versus a low value service. And so the payments don't really differentiate based on those criteria. And when we think about fee for service for primary care, we're particularly thinking about is why it on its own doesn't really work. I would say just generally the comprehensive relationship-based nature of primary care is really inconsistent with this fee-for-service mechanism, which is really built around the payment of discrete services. So go into a practice, look at the tasks, look at who's involved in doing them, measure those, value those, and that is essentially what constitutes fee-for-service payment. But if you think about what comprehensive, high-quality primary care really is, it's difficult to measure or break it down into a series of specific tasks. And therein lies much of the problem related to fee-for-service as the primary or sole mechanism of payment for primary care. First of all, many of those activities that are involved in delivering relationship-based comprehensive care are not valued as specific activities in the fee schedule at all, so they're just not paid for. Those that are identified as specific tasks or activities generally are undervalued through this very complex and technically difficult process of valuing how much payment goes with each of those tasks or activities. This some of you may know as the ROC, which is the Resource-Based Relative Update Committee. And then when it comes to sort of actually getting paid, each of those codes that you can submit billing for has its own set of checklists and requirements. And so I have, as from a documentation point of view, we know that that's been burdensome and problematic for primary care to document not only the problems, why are you doing this, but also what are you doing, and making sure that you've checked all the boxes associated with each of those payments. So for those reasons, we've talked a lot about what else do we need, and especially if we want to increase investment and we want to add payment for primary care in a different way, what do we think that looks like? And so that leads us to sort of value-based payment. And what I want to start with is the really good intentions of value-based payment. And what you see reflected on the slide here is sort of in this chevron is sort of the evolution or the sort of continuum, I guess I would say, of value-based payment types. So starting at the far left, you've got just straight fee for service. When we started sort of adding into it this idea of being accountable for outcomes and other aspects of care delivery, we added pay for performance. And then when we recognized certain aspects of doing that required extra effort, we added care management fees. And then you get into accountable relationships, ACOs, clinically integrated networks, and you introduce opportunities like shared savings or shared risks and savings. And then you also have the opportunity to take accountability for a population of patients through capitation or even on an either partial or full basis. And so when you think about the intentions of value-based payment, it was really about trying to change the incentives. So if we think about what the incentives are across this chevron, we start on the left with fee for service, and the focus is really on my schedule and the services I'm delivering one patient at a time. And the incentives are things like filling appointments and maximizing limited time with patients. The intention of value-based payment, and I think the really good intention of value-based payment, is to sort of introduce the idea of value-based care centered around an accountable patient population, which really drives incentives of things like coordinating care, closing gaps in care, managing referrals, addressing social determinants of health, integrating behavioral health, and preventing disease in its progression. So the ideal is that the payment mechanism is matched with doing those services. And as you're listening to this, I hope you're hearing a lot of sort of where lifestyle medicine can play in this, and where I think Dr. Patel will really help bring that to life in her portion of today's discussion. So I want to talk a little bit about transitioning to value-based care and why, what happens when that transition really works and what is changing in practice. Part of that is thinking about patients not on the schedule. So you've got now to have an accountable population that requires your attention, and what's happening outside of your primary care practice matters just as much as what's happening within the practice. Avoiding or reversing disease produce value, and I think that is one tenet of this shift to value-based care that is really highly aligned with the lifestyle medicine perspective. Unfortunately, we know that only some of that value is actually really being efficiently or effectively measured today. So that's one of the things that the AFP we're leaning into a lot and spending a lot of our time and energy on. But the final thing I wanted to point out is that the level of patient engagement really impacts outcomes. And I think that fundamentally thinking about how to engage patients differently for so many primary care clinicians and physicians is such an important aspect of this, and something that lifestyle medicine has really given us a footprint for how to lean into that and how to make that work. And I think you'll see that and hear that in the balance of the presentation from Dr. Patel. So as we think about sort of the payment piece, we know we need to pay more and we know we need to pay differently. I want to talk just a minute about value-based payment and what we think is actually really, I wouldn't even call it value-based payment, or we're not at the AAP calling it value-based payment as much as we are just really well-designed primary care payment. And what do we think that should look like, and what elements do we need to think about to understand whether that's actually being implemented or not? So this is actually representative of AAFP policy on primary care payment that calls for the following things: to pay prospectively to support team-based care and ensure payments actually reach primary care practices, to really actively engage patients in the accountable relationship, to make sure that payments are always risk adjusted for both the medical and social complexity of the patient population, to make sure the payments are accurate, and really support the work that you have in front of you as physicians and clinicians, to evaluate what matters the most to patients and physicians. That gets to the point about outcomes that I was referencing earlier, to make sure that primary care teams are equipped with timely information. Again, what matters is not just what's happening within your practice, but what's happening with your patient population outside of your practice as well. And that information flow is improving, but it still has a long way to go. And that the payment mechanism ought not to be built on purely year-over-year improvements, but that it ought to also recognize sustained high performance. And that as we implement all of this, it's done with an equity lens in mind. And so I think if I had to sort of point to one of these boxes that is really fundamentally most important and relevant to our conversation today, I think it would be to pay prospectively to support team-based care. It gets us out of, and I think you may be hearing a lot about hybrid payments and how important hybrid payment is for primary care, which is actually one of the fundamental recommendations from the NASM report on implementing high quality primary care. We're actually seeing real movement to sort of move primary care away from sole reliance on fee-for-service and introduce new opportunities to have prospectively paid population-based payments. And I think the importance of that and relevance of that to our conversation today is really around building the care delivery model, whether that's premised on lifestyle medicine or something else. It gives primary care practices that flexibility to reach into the toolbox across the primary care landscape and choose the elements that work best for them. Finally, the third point, that we come from different perspectives, we use different words, but we're really describing high quality primary care. I want to go back to the NASM report once again, where they really, in their definition of high quality primary care, I think gave us the words and the tools to think about this and the crosswalk between primary care and whole health, and all of the other elements that contribute to that, including lifestyle medicine. So you'll see a lot of words on the slide, some of which are bolded, which are really the ones that stand out to me around being whole person, integrated, accessible, and equitable health care delivered by interprofessional teams. You'll hear a lot about that from Dr. Patel. Accountable for addressing the majority of an individual's health and wellness needs, not just when they're sick, but how do we want to improve health so I can go on the hike or take my grandkids to the park? What are those sustained relationships like, not just with patients, but with their families and the communities in which they live? Whole person health was also actually referenced in the high quality primary care report as focused on well-being rather than the absence of disease, accounting for the mental, physical, emotional, and spiritual health and social determinants of health of a person. So whole health care and value-based primary care have a whole lot in common, built on the foundation of a high quality, well-supported primary care infrastructure, is the words that came out of the most recent NASM report on achieving whole health, a consensus study report that was just published in 2023. It really leans into primary care as being the fundamental foundation for whole health care delivery, talking about how it is cross-sectoral, spanning conventional medical care, disciplines and domains, including mental health, health behavior promotion, complementary and integrative health, public health, and social services. And so with that foundation, I will turn the balance of the time to Dr. Patel.
Thank you, Karen, for making that clear statement that lifestyle medicine is synonymous with whole health. And it is not also what we describe, is also what we describe as high quality primary care. Let me explore how lifestyle medicine fulfills the foundational elements of whole person care and offers a clinical framework to deliver whole person care in the current reimbursement models. Yes, we need better payment models for primary care, but 3 distinct lifestyle medicine models offer a framework for a whole person approach even today. So let's first review the 5 foundational elements of whole health described in the NASM consensus study report. The person-centered approach is a key aspect of achieving whole health. It involves delivering care in the social and cultural context of individuals, families, and communities, thereby helping them achieve a sense of purpose through longitudinal and relationship-based care. The comprehensive and holistic approach care focuses on the entirety of a person's being and ensures that it addresses all domains that affect health with integrated and coordinated care teams. Upstream focused, the multi-sectorial, integrated and coordinated approach to identifying and addressing root causes of poor health, addressing the structures and conditions of daily life to make them more conducive to whole health. Equitable and accountable. Whole health systems need to be accountable for the health and well-being of the people, families, and communities they serve. Team well-being. The health of the care team needs to be supported. The American College of Lifestyle Medicine has a task force which is working to define lifestyle medicine high-value framework, and they finalized these core elements. The lifestyle medicine core elements can be viewed from 3 domains, from the perspectives of the person or patient, the provider and the team, and the health system. Whole health means care is centered on person's needs and cultural context of individuals and communities, is comprehensive, integrated with behavioral and social needs, and is equitable, all necessary components to advance population health. Care is evidence-based, sustainable, and delivered by lifestyle medicine trained providers leading an interdisciplinary team of clinicians, including registered dietitians, behavioral providers, and health coaches. This comprehensive team-based approach is ideal for patient activation and empowerment, leading to better patient engagement. Patients and providers are within an integrated health system, working in a coordinated, aligned manner. The health system is accountable, and the care is affordable, accessible, and scalable at all points of care. So why are we talking about lifestyle medicine? Because clinical practice guidelines for many chronic conditions, including cardiovascular disease, diabetes, hypertension, dementia, and cancer, recommend lifestyle interventions as a first line of treatment. Lifestyle medicine clinicians have expanded conventional medicine's foundational first line of intervention by integrating the 6 pillars and using medications only as needed. However, because there are no quality measures or financial incentives for lifestyle medicine, the standard approach is to use prescription medications immediately. And this is especially true because we have a list of quality measures focusing on medication adherence. So how is lifestyle medicine care different from traditional primary care? What sets an LM clinician apart is their mindset. They're not just focused on fixing what's broken, but on finding balance. The patient is an active partner. The care plan is based on lifestyle medicine vital signs. The care team collaborates with patient needs and is focused on quality of life and what matters to patients. Since the treatment plan is based on shared decision-making and patients are empowered with knowledge and skills, they are more likely to adhere to a treatment plan that is mindful of their culture and values. Addressing all domains of health requires screening for social determinants of health and addressing health-related social needs. SDOH are conditions on the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. It is important to screen for SDOH and address them by partnering with community-based organizations. Health-related social needs at individual level, adverse social conditions that may negatively affect a person's health or healthcare, such as food insecurity, housing instability, and lack of access to transportation by using SDOH data to address health-related social needs. health outcomes can be improved by strengthening relationships and communications among patients, healthcare teams, and the broader healthcare community. Community-engaged lifestyle medicine framework was developed in 2015 by the University of Texas Rio Grande Valley Preventive Medicine Residency Program to address lifestyle-related health disparities within marginalized border communities. The framework includes the following evidence-based principles: community engagement, cultural competency, and application of multi-level and intersectoral approaches. In clinical practice, addressing all domains of health means focusing on prevention, treatment, and remission of chronic diseases. One of the strengths of lifestyle medicine is the longitudinal and coordinated nature of the relationship between the patient and the clinician, which is the ideal situation for implementing a whole person approach that is focused on long-term behavior change to prevent, treat, and even put chronic diseases into remission. There are foundational lifestyle medicine elements, and when implementing lifestyle medicine into clinical practice, patient care involves the use of screening tools to assess the patient's current health behaviors in the 6 domains, and then working together to identify achievable steps toward optimizing these lifestyle behaviors. Lifestyle medicine prescriptions are developed using a detailed history, written using SMART approach, which is specific, measurable, accountable, realistic, and time-sensitive, and applied by giving patient a concrete action plan as they leave the healthcare interaction. Cohort-based delivery model, shared medical appointments, where a group of patients with similar diagnoses gather with the healthcare team for education, goal setting, and group support, are also an effective way to integrate lifestyle medicine into the clinic workflow. Having access to a multidisciplinary team, either within the practice itself or as a referral network, is an important component of successful lifestyle medicine implementation. And one of the strengths of lifestyle medicine is the longitudinal and coordinated nature of the relationship between patient and the clinician, which is the ideal situation for implementing an approach that is focused on long-term behavior change to prevent, treat, and even potentially reverse chronic diseases. And as Karen said, instead of focusing on different perspectives and terminologies, let us focus on what matters to patients and their clinicians. It is great to have all of these foundational elements and frameworks, but how do you translate them into patient care in the real world? The good news is that 3 distinct lifestyle care models offer the framework to integrate whole person health into the current payment models. Yes, we need better payment models for primary care, but we don't have to wait. We can start delivering these models today. One of the models is lifestyle medicine shared medical appointments. And these are a new way of delivering healthcare that differ from traditional medical appointments. This allows clinicians to interact with multiple patients simultaneously, delivering care in a group setting. All participants receive healthcare services within a group environment, including education, counseling, group support, physical examinations, and encouragement. Lifestyle medicine presents effective clinical models that incorporate interdisciplinary members as part of their core team. These allows for team-based care to be delivered during medical appointments, providing a new vision for primary care that could be crucial for improving the nation's health. Core team incorporates primary care clinician, patient, and family, registered dietitian, nutritionist, certified health and wellness coach, registered nurse, medical assistant, and office staff. Extended care team include pharmacist, culinary chef, behavioral health specialist, exercise specialist, social worker, physical therapist, occupational therapist, care manager, and community health worker. Many other team members might support the 6-pillar behavior change that are not depicted in this diagram, including but not limited to substance use professionals, sleep specialists, marriage and family therapists, and other specialists. Others may also address meaning and purpose, such as spiritual and religious leaders and psychologists. Care and care team referrals should be tailored to a patient's individual needs based on the clinician's judgment. So what are the benefits? Well, it improves access and efficiency, reduces administrative costs, improves clinical outcomes. It enhances team well-being and improves patient experience and clinician well-being. And they can be delivered in person as well as virtually. And we have seen a variety of models, can be condition-specific sessions or could be for multiple chronic conditions altogether. Having 12 to 15 patients in a group allows a clinician to generate about $1,300 per hour instead of one-on-one 15-minute encounters for the same number of patients, where they generate about $520 per hour. Now, this allows for them to have that flexibility to offer additional educational materials and tools and incorporate interdisciplinary teams into patient care. And here is a story of my patient that I wanted to share.
I was a diabetic since probably somewhere 2003. Whenever I came here, I was at 341 pounds. As I'm into this thing for 9 months, when I got on my scale at home, I was 267. I'm able to go, hiking in the mountains. I've taken up biking. I have way more energy when I go to the gym now. To say it's life-changing is not, it's not strong enough of a word. It if you follow what this class has to offer, you can literally change your life. It's more than just reversing diabetes. It's a health makeover as well. Going into my 30s is when I developed diabetes, and going into my 50s because of the Lifestyle Medicine Center, I'm beating diabetes.
The second lifestyle medicine model that offers team-based care and whole person approach is intensive cardiac rehab. One reason we should talk about ICR is that heart disease is the #1 killer in the US, and ICR is one of the only lifestyle medicine programs with a reimbursement model. It's concerning that only 10 to 20% of eligible patients are referred to cardiac rehab, highlighting the significant gap in care and the potential for ICR as a revenue source for primary care providers and specialists. Unfortunately, instead of being proactive in our approach, we wait until people have a cardiac event to offer this holistic care model. Because our current reimbursement models only cover those who have acute myocardial infarction in the last 1 year, history of bypass surgery, history of stable angina, heart valve repair or replacement, history of stent or angioplasty, heart or heart-lung transplant, or history of congestive heart failure. There are 3 CMS-approved ICR programs that you can partner with. Even as a primary care clinician, I've successfully developed and delivered the Ornish program and Predican programs during my work at Midland Health. The advantage of ICR is that you have 72 reimbursable sessions, which means double the reimbursement. Each visit includes exercise and educational component provided by interdisciplinary teams. The Predican program's educational curriculum is centered on 3 key pillars: regular exercise, heart-healthy nutrition, and healthy mindset. This comprehensive approach equips patients with the tools and knowledge they need for success, both during cardiac rehab and long after the program is complete. Dr. Ornish's program consists of 4 equally weighted modalities that examine the whole person, not just their diet. Dr. Ornish found that addressing these 4 elements, exercise, stress management, community support, and nutrition, can result in significant lasting change. The program itself is 72 hours over 9 weeks and is delivered by a trained interdisciplinary team. After the 9 weeks, they continue to provide tools and support through an alumni program that helps foster lasting change. During the pandemic, virtual cardiac rehab became a successful alternative to increase patient access, improve participation and graduation rates, and to strengthen program performance overall. And both Pritikin and Orange program offer virtual cardiac rehab options. The virtual programs offer opportunities for clinicians, including PCPs, to bill for these services without any upfront cost by collaborating with external partners that offer turnkey solutions. And here is your reimbursement, $115 per hour. And if a patient completes 72 hours of services, you can collect $8,350. This is from CMS. And obviously, commercial insurances do pay higher than this. This is if you have on-site ICR program. And here is a powerful story from one of my patients from ICR.
Oh, I knew I needed a change, a transformation, and then I had a cardiac cath that revealed I had some blockages, and my physician recommended extreme lifestyle changes. So I've been type 1 diabetic for 34 years, so I was at increased risk and went to the Lifestyle Medicine Center at Midland Memorial and made a big difference. In the beginning, it was interesting. It was a little bit difficult giving up some of the things that I ate on an ordinary basis. And then as I started to see the changes, I can't give that up. So it's much easier now, and I'm learning new things and trying foods that I had never tried or I hadn't eaten much of in a long time. So it's kind of like learning to eat again, which is kind of nice. I have lost 71 pounds. I have dropped my Humalog insulin use by about 75%. I've stopped almost all of my medications that I was on. And the outward transformation is the least of it. I feel like I've been raised from the dead. My energy level's up. More energy to do things. I don't have the exhaustion and the shortness of breath, the dizziness that I was experiencing, and my chest pain and left arm pain is gone. It's gone. I would say take the jump. Don't wait. Intellectually, I knew these things for a long time. I'm a registered nurse and I help take care of other people. And I wish that I had done this long before I did, because it's made such a difference in the quality of my life. So take the jump, start slow, and connect with the resources in our community, which are so strong that will help you with this. So I would encourage anybody to speak with their physician or do some independent research and look at the Lifestyle Medicine Center and the resources that our Healthy City and Midland Health provides. It's pretty incredible for a town the size of Midland.
All right, and the third model that I wanted to briefly share is the collaborative care model with lifestyle medicine integration. The classic evidence-based collaborative care model was initially designed to address behavioral health within primary care. The researchers later learned that it also improved metabolic diseases along with mental health. We know that 30% of adults with chronic diseases have some mental health disorder, and 70% of behavioral health patients have a medical comorbidity. So it makes sense to have a whole person approach to patient care. In the CMMI demonstration, return on investment was very clear. For every $1 investment, they were able to demonstrate the $6 cost savings. Lifestyle medicine integration into the traditional model of collaborative care model incorporates and addresses lifestyle behaviors to address physical health and mental health to deliver what we call as a whole person health. It's an ideal whole person health delivery model, considering there's so much significant overlap between physical and mental health. It also provides an interdisciplinary team to support patients with a reimbursement model in between office visits, something that they have struggled to offer all along. And when you address the physical, mental, behavioral social determinants of health, and lifestyle medicine, you truly deliver whole person care. Implementing collaborative care model into patient care can be challenging for busy primary care clinicians. The good news is that external partners offer turnkey solutions now. Collaborative care model reimbursement is about $300 annually if you have a patient that can be added on collaborative care services with an external partners. And if patient qualifies for remote patient monitoring along with that, there could be additional $200 as well. So on average, a primary care provider can generate somewhere around $500 by offering this whole person care and collaborating with external partner. And here's a patient story that's very powerful, and I would love to share that.
I'm Sister Joy Ann Sullivan. I'm a sister of Notre Dame. It was towards the end of my 15 years as a nurse that I was developing these terrible pains, and they just said it was fibromyalgia. The doctor just said, well, you can try these medications. But when I moved to Ventura, and one of the doctors up there said, we're kind of researching this, and we think food has something to do with triggering the pain. I said, if anything that helps me and keeps me going, I'm interested. And that's how I got introduced to this program. And it was basically coming down to what choices do I want to make? I want to be healthy. I want to continue doing what I love to do. And when the pain is so bad, you can't hold a paintbrush, darn it, I'm going to see what I can do to make this better. Following the directions of the health counselor, Angela, the nutritionist, and now the physical workouts that I'm doing that we just started, I just feel fantastic. I have so much more energy. I see the benefits in my own life, and I can keep doing the things that I love. You know, this program has really just given me a new lease on life.
So quickly talking about whole person health and value-based care, we have annual wellness visits where we can integrate lifestyle medicine prescription, as we talked about earlier, creating a SMART goal and giving a concrete action plan. There is also a lifestyle medicine shared medical appointment, which can be also used for chronic disease management. And then intensive therapeutic lifestyle change program is ideal for patients who are high utilizers. Looking at this traditional utilization pyramid, we can use traditional therapeutic lifestyle change programs for low utilizers and moderate utilizers. And for high utilizers, the ITLC program, which focuses on disease remission with evidence-based, comprehensive, multimodal approach, and have multiple sessions over a short period of time, delivery through multidisciplinary teams, which offer education and behavioral health support. And there is focus on continuous improvement and measurement of specified health outcomes. There's fantastic results we've seen from some of the early trends here, clinicians who are lifestyle medicine certified in a value-based care model. This is from Poplar Care Network, which is a small ACO with all lifestyle medicine certified clinicians, demonstrating significant reduction in hospitalization and ER visits in their first year of ACO REACH participation. And here's a example from Dr. Wayne Dysinger, his lifestyle medical practice in Southern California, participating in Medicare Advantage and demonstrating triple aim, improved health outcomes, 40% cost savings, and happy patients. So here's your take-home message. The transformative lifestyle medicine whole person care model can deliver the quintuple aim of healthcare. Better health outcomes because it proactively addresses the root cause and focuses on prevention, treatment, and remission. Improved patient satisfaction because patients feel empowered and engaged because it delivers person-centered, collaborative, interdisciplinary, and whole person care. It lowers the cost of care by reducing avoidable ER and inpatient admissions and high dollar utilization procedures, and aims at disease remission and medication deprescribing. Also, whole person care is accessible and available to everyone. Everyone deserves information about disease remission, personal well-being, and longevity. This should not be limited to only affluent communities. And when 62% of clinicians report experiencing burnout, it is worth knowing that lifestyle medicine brings professional satisfaction and the joy of medicine. 90% of clinicians reported that integrating lifestyle medicine into their clinical practice had positively impacted their professional satisfaction. With this, I'm going to end my presentation, and Karen and I will be available to answer any questions. Thank you.